Clinical Habit, and Professor of Surgery and Urology at Lerner College of Medicine at Case Western Reserve University in Cleveland, Ohio. Dr. Fleckman has authored more than 220 scientific papers, review articles, and book chapters. He is famous worldwide, not only in the United States, and he is associate editor of Journal of Clinical Transplantation and editorial board member in Journal of Transplantation. We welcome you to Mansoura. To my best knowledge, this is your second visit to the center, and we hope for future mutual work together. Professor Shukera and Professor Adil Bakr will chair this session. Welcome, Professor Fleckman.
Good afternoon. We are going to start this afternoon session by a lecture from my Immunosuppression, Renal Transplantation, past, present, and future.
Well, thank you very much, and certainly thank you for that lovely introduction. I think my mother must have written it and sent me the expression. Dr. Shohair, Dr. Abubakar, thank you again for the lovely invitation. This is a rather wide or large subject, and I thought what I would do is a way to perhaps discuss this for those who are involved or with care of transplant patients, or for those who are not, or just to give you some background about why we do what we do. Sometimes it's understandable and based on evidence, and other times is a little bit just based on experience and how we've evolved. I advance just as we're on computer. Okay. So let's talk about the past, the present, and the future, what we mean by that. The past and how we got there, how we developed some of the thought processes and practices that we do. Well, what we can say is transplantation has been around about 60 years, but the longest surviving transplant recipients were in the late 50s, and these were actually the third successful transplants done. The first successful human transplants were done in Boston in 1954, and they were between identical twins. And it was well known based on Medawar's work and Billingham and Brent from the late 40s and 50s that there was a process of rejection, and rejection would occur. So that's why the first transplants were in identical twins. And these sisters both did very well. The recipient actually had a few children in her life. But they were the sort of ideal, they were the best outcomes because being identical twins, they had very minimal, if any, alloimmune activity. But what was interesting to me is if you actually look at what was known about identical twin transplants, there were about 120 done in the United States and 10, 12 done in England. And what's fascinating is how many of these patients were on immunosuppression. So many of them were thought to be on nothing, but a lot of them were on low-dose prednisone or azathioprine and some of the other agents. And the reason is many of them were transplanted with autoimmune disease, glomerulonephritis, and the types of diseases that can be occurred. So what was important, I think, was the idea that not just rejection, but there are other reasons why grafts can fail. And if you look, this really isn't so great, is it? Graft survival is about 90% at 5 years. That's a big number, but you would think it would be virtually 100%. But there is some graft loss in HLA identicals as well. Now, this kind of summarizes, I think, immunosuppression from the beginning to where we are today. And the early proponents and practice of immunosuppression began with a very, very distorted arena here, where 90% of patients experienced acute rejection, and survival was less than 50%, and year. And this was generally just using what we now would consider minimal medication. But the target for 30, 40, 50 years has been this, acute rejection. So we now are in a current environment where greater than 90% of grafts function at a year and acute rejection rates of 10 to 15%. Now there's a price to be paid for that, and I'll go into that more with you, but we have been quite successful in going from this terrible early start to where we are today. So let me give you what I consider what we've learned. There are 3 bedrock principles of transplant immunosuppression. And it's not surprising what I'm going to tell you. It's what we've learned in preclinical studies in the laboratory and then was reproduced in humans. And the first principle is that alloimmunity follows the same rules as the immune response to other microbes and foreign invaders. And the ability to identify self from non-self, specificity, memory, amplification. These are all principles of the immune response, and they work directly the same versus an allograft. Whether it's a heart, kidney, liver, etc., it doesn't matter. The same thing goes on. The second bedrock principle is something we clinically borrowed really from our friends in oncology. And that is that the cell cycle of a lymphocyte responds to immunosuppressive drugs like a cancer cell to chemotherapy. And what that principle means is one immunosuppressive agent may be very, very potent, and you can give enough of it to prevent rejection, but it's generally too toxic for a patient to sustain. So in, let's say, transitional cell cancer, we can kill all transitional cell cancer with a platinum agent, cisplatin. But in order to do that, sometimes the dosing would have to be so high of platinum that it would be too toxic for the patient to withstand. So that conceptually, if we use lower doses of drugs that attack different points of the cell cycle, then this can be, in a sense, synergistically put together to make a regimen or a cocktail that's quite effective. And the third bedrock principle of immunosuppression that I think we've all learned is that clinical immunosuppression is a careful balance between too much and not enough. And you can't say it any differently. Either you're giving someone too much or you're giving the person not enough. They have not enough, too little. They can experience rejection or recurrent disease of autoimmune disease. If you give them too much, they experience opportunistic or routine infections and cancer. And we don't really have a specific number. I can't tell you that that particular patient or that particular organ needs that much immunosuppression. It's an overall amount. So that putting these all together, we have kind of rules or principles that we go by when we practice. One is that it's important to prevent the primary immune response, and that no acute rejection is better than some rejection. It's better to use just what I said, lower doses of multiple immunosuppressive drugs that work at different points of the cell cycle. It improves tolerability and toxicity. And that the total amount of immunosuppression should be decreased over time as the host accommodates the foreign HLA phenotypes. And that's a learned experience over decades. Sorry for this very busy slide, just to make a principal point, that we target the immune response, or I call it different points in the cell cycle, by the initial presentation of cells. Ultimately, after proliferation and sensitization occurs, the two signals, signal 1 and co-stimulation, we then get stimulation of naive, or activation rather, naive T cells that turn into activated cells that produce cytokines, and these cytokines feed back on other clones of activated cells to expand the arrangement. So there's amplification. So this whole busy slide is just telling you there are always opportunities for new agents to come along that can target different points in the cycle. So what we're left with, perhaps in a more simplistic way, but in a practical way, with immunosuppression, is we deliver it in 3 different strategies. The first strategy is to deliver what we use the term induction therapy. It's to give high-dose therapy to prevent the primary immune response. We do this to knock out immune-activated cells, decrease so-called passenger leukocytes that come with the graft that are allostimulatory, and then permit resolution of ischemic injury in the case of a kidney. Maintenance therapy is what most patients take every day. It's the lowest dose tolerated therapy to prevent rejection. We want to, of course, minimize it, minimize toxicity, minimize side effects. And then lastly, we have to come up with different regimens to treat rejection if it occurs by boosting the immunosuppression delivered either with biological products or oral agents or combinations thereof. So that's what we've learned really over 50 years, and how we apply this, I think, varies different parts of the world, different practitioners, although all these themes come into play. So in the present, and this is data from North America, obviously I'm showing you North American data, I don't have specific national data in the Middle East or Egypt, but I think the principles are the same and the findings are the same. We have a terrible imbalance in the total number of people waiting for a transplant and how many we do. In the United States, we've done about 16,000 to 17,000 transplants for 10 years. Interestingly, we don't really do more. We're at a point where we capture just about the most deceased donor organs we can, and then we waste some or we discard some. That's an opportunity to improve, but we don't get more. And we haven't had a big increase in the number of live donor donors. They've actually dropped a little bit, but perhaps now with this notion, we can talk later about this pair exchange, we may be able to do some more. But this is kind of this terrible imbalance we have. And there's an active mortality on the wait list. It's about 6 to 7%. People sometimes forget that. So patients that wait for an organ have a mortality. They're really suffering when they don't get transplant. So what about transplant outcomes? We've all come to establish sort of benchmarks about what outcome is, and we talk often about what the rejection rate is in a year, and then what is graft survival in 1 year. And since the results are quite good, they're over 90%, we sometimes get a little bit mentally lazy about this, or think that we're doing such a good job. But the reality is there's quite a steep loss of grafts that begins at about 5 years. Even from 1 to 5 years, we lose a good number of grafts, but by 10 years, less than half of the deceased donor kidneys are working, and only about 60% of the live donor kidneys. So that's a pretty steep rate of loss if you consider the only alternative to that is that patients have to go back on dialysis or get another transplant. Now, one of the sad realities, and this is not related to folks here, but you can see what play it has, is sometimes how insurance coverage gets very involved and how medical care is delivered. So the United States can quite unproudly say that they have 10% worse graft survival than Canada, Europe, and the United States, and the United Kingdom. You can see that there's a cluster here, about 80% at 5 years and about 60% at the high 50s, and yet the United States is worse. And we think one of the driving forces of that, why it's worse, is most of the patients who are on government health insurance only get immunosuppression paid for 3 years. They don't after 3 years. So patients have problems. They have problems paying for medications. It can become expensive and lead to drop-off. And clearly that impacts these long-term outcomes. So immunosuppression is required long-term, and it's something that we really need to consider. The second thing we've become better at is learning in a predictive kind of way that